Aloha, I am Dr. Eliza Kim, and this is Everyday Wellness. We're continuing on with our series, Whole Wellness, and this is a part 2 of the thyroid conditions. Thank you for joining us today, Dr. Kristen Coles.
Thanks for having me.
Yeah, thank you. So we'd like to go ahead and continue on with this iodine regarding how it relates to the thyroid conditions, and also, just a little bit more about the goiter.
So the thyroid gland, which sits in the neck, is the primary gland that accumulates and concentrates iodine in our body. Iodine is used to make our thyroid hormones, so it's a very important nutrient and mineral to have in our system to help the thyroid function. Now, we were discussing that in this country, we don't have an issue with iodine deficiency per se. Most of our food is fortified with it. The recommended daily allowance of iodine is 150 micrograms a day. If you are getting less than 50 micrograms of iodine, there is a big concern for your thyroid and creating something called a goiter and a hypothyroid state. Now, if you're someone who's been told to stay away from all salt, maybe you have a blood pressure condition, or you have an issue with kidneys or edema, and you've been told not to eat any salt, that is more of the people that I see who might not be getting enough iodine. But the majority of Americans in this day and age are getting their recommended daily iodine intake. But certainly doing things like sea vegetables, seaweed, kelp, things like that on a daily basis is a great way to get bioavailable iodine.
Like wakame, hijiki, all that.
Oh yeah, any of those seaweeds that we like to eat, or even the dulce granules that you can just sprinkle over things. That's seaweed. That will provide you with some of that bioavailable iodine, which is great for your thyroid.
You're talking about the furikake, right?
Yeah.
Yeah, exactly. Well, so what kind of testing do you do for the thyroid conditions in your office?
Well, as a naturopathic doctor, I do more in-depth testing of the thyroid than most other doctors do. And my understanding of the thyroid is about how complex the system is. The majority of patients who come to see me who have been sort of doing conventional medicine for most of their life, and they have either never had a thyroid test done, or they will tell me they've had their thyroid tested and it was fine. However, when I go through the entire hour-long intake and I'm going through all their symptoms, everything that's going on, and there's a lot of thyroid symptoms coming up, but they've had their thyroid tested, A, I want to see what tests have been done. And B, when I do see what tests have been done, usually the only thing that's been run is something called a TSH. That's a thyroid stimulating hormone. The normal range for a TSH is about 0.2 to 4.5, depending on which lab you use. So it has a pretty big range, actually. Now, the TSH is one of these interesting markers where if you come back at 4.4, you're normal. Let's say you come back in 6 weeks and you're 4.56, oh, you're borderline. You come back again in 6 weeks later, you're 4.6. Now you are hypothyroid. Right. So that line is very sort of dramatic versus the way I look at things. I sort of look at progression, and I'm a preventative doctor. And if I see a patient come in and their TSH is in the ideal range, which for me, ideal is 1 to 1.5 on a TSH. Anything greater than 2.5 that I see on a TSH is grounds for potential treatment and a much more thorough workup. Okay, so when I run a thyroid panel, I run a TSH. I run something called a free T4, a free T3, often a T3 total, often a reverse T3, and thyroid antibodies, anti-TPO, anti-thyroglobulin. For me, that is a full and complete thyroid workup. And in some cases, I'm not going to be satisfied until I have a full and complete workup in front of me before I can really tell you that there's no issue at all with your thyroid.
And what is about T7 that I always tend to see on a lab? You know, where it comes from other labs.
Yeah, so T7, reverse T3, different names. So that's like a way that T4 turns into something that looks like T3, but it is not.
Right.
And that will actually cause hypothyroid if those levels are too high. Yeah. So we want to make sure that your TSH is in the ideal range.
Right.
And then that's a good start, but most of the time people only have a TSH done and they don't even have any of the active thyroid hormones run.
Right.
And we want to look at T4, but we also want to look at T3.
Right.
Now, if you're just tuning in, the last episode we talked about what these TSH and T4 and T3 markers mean. T4 is the most abundant of our thyroid hormones, but it is not very active. T3 is the most active of our thyroid hormone.
Right.
So it is the one that is actually going to go to your cells and make all those changes to your cell that we need. Help our metabolism, help our mood, help our energy.
Right.
That's what T3 does. So it really just every day continues to blow my mind as to why that marker is consistently never run.
Right.
Because really, if we're trying to understand if the thyroid hormone itself is decent and functioning, we want to look at what's most biologically active.
Right, exactly. And do you realize how many of those patients come in and they're very clear themselves that they have thyroid symptoms. However, when they speak to their general practitioners about it, they will run maybe the TSH, but many times if they ask for an in-depth panel, they get denied for it, which is absolutely sad because the TSH a lot of times will show up normal and they're told that they have nothing wrong with thyroid. And unless that TSH shows something wrong, they will not run the panel.
Yeah. I hear that story every day in my office. And it is a shame. I have people who for 15 years have felt that they have been struggling with thyroid issues and the only thing that's ever been looked at is a TSH, and it might be in the 3s, which to me is concerning.
Right.
But they've been told over and over it's normal. No other workup has been done.
Right.
I had a patient a few weeks ago, and she brought in her labs that had been done by her general practitioner, and I was looking at it and I saw a TSH had been done, and it was a little over a 3. And so I went back and looked at the one she had done a year ago, and it was about a 2.5. And the fact that it has sort of been trending in a more hypothyroid direction caused me to say, you know what, I'm going to do some additional labs, and I'm going to do a full panel. And her thyroid hormones actually came back within normal. They weren't quite ideal. But what did come back positive was her autoantibodies.
Interesting. Yeah.
So what we're going to get into is some of the types of thyroid conditions.
Right.
One of the main types of hypothyroid is called Hashimoto's thyroiditis.
Right.
This is an autoimmune condition of the thyroid. And there are 2 very important autoimmune conditions that affect the thyroid. And Hashimoto's is the one where we tend to be in a hypothyroid or a deficient thyroid state. And so this patient of mine, her thyroid is still normal, quote unquote, but she was creating antibodies against her thyroid. And she has signs and symptoms that would be similar to subclinical hypothyroidism. So this is a patient who 10 years down the line, she would have overt hypothyroid disease. Her TSH would be very much abnormal, and her T3 and T4 would probably be very low. And she would be in a hypothyroid state because of the destruction of her thyroid during all this time where it was never detected. So what we have done with her is we have started therapy, and will basically prevent the destruction of her thyroid and over time until the point where she would, be looked at as medically hypothyroid. And that, that's one of the beauties about being a functional medicine practitioner, is that we know that there's so many other pieces that have to be looked at beyond just what, maybe insurance is going to pay or conventional doctors are going to run.
Right, right. That's very, very true. So what are the other, can you go into the Graves' disease? Because we get that a lot too, right?
Yeah. So 2 different types of autoimmune thyroid conditions, Hashimoto's and Graves' disease. Graves' disease is an autoimmune condition where the thyroid actually gets stimulated.
Right.
So we enter into a hyperthyroid state. And we haven't touched on hyperthyroid much, but the sort of signs and symptoms of a hyperthyroid state include heart palpitations, a racing heart, anxiety, nervousness, insomnia, tremors, issues with muscle spasms, muscle weakness, if it's swelling around the eyes, orbital swelling. If it's left untreated, it can cause very severe issues with the heart and other sort of nervous system issues. And Graves' disease is an autoimmune condition that is the most common cause of hyperthyroid.
And that's one of the reasons why the orbital swelling is what makes their eyes to kind of pop out more, so you really, really see like almost the white parts of their eyes. Right?
Yeah, and in very bad cases, the eyelid almost can't close over the eyeball itself.
Right, right.
Yeah,
right.
and that's due to the autoimmune process that's actually attacking the sort of subcutaneous fat around the eye itself. Autoimmune thyroid conditions, Graves' disease gets tested for often if hyperthyroid is showing up.
Right.
Graves' disease is often tested for.
Right.
The other piece, the Hashimoto's, the low thyroid, that is almost never tested for, even though that's one of the main causes to hypothyroid.
Right.
In conventional medicine, there is no difference in treating a hypothyroid state or a Hashimoto's hypothyroid state. They're all given the exact same treatment. And in sort of my sort of world and how I practice, there's actually huge differences between an autoimmune condition versus just a low functioning thyroid. So the treatments that I give to just a hypothyroid versus a Hashimoto's autoimmune hypothyroid are going to be different. And Graves' disease patients, they are often they are treated conventionally because the condition does have such a concerning sequelae if it's left untreated. The treatments for Graves' disease is often surgery or specific drugs or radioactive ablation to stop the thyroid itself.
Right. I've actually had some of the male patients, have the Graves' disease and go through the whole radiation, and it's very interesting how they treat those. Can you go over maybe the difference between the natural or the holistic way of treating some of these thyroid conditions versus the conventional way of treating it?
Absolutely. Well, first and foremost, and I'm going to talk again about hypothyroid since that really is the most common that we see, a subclinical low functioning thyroid. First things first is let's make a proper diagnosis. So let's do and run the labs and the full thyroid panel and the full workup that we need. Second is let's determine if the cause or the origin of your low functioning thyroid is an autoimmune issue or something more like a conversion issue or a micronutrient issue and just a regular hypothyroid state. That's a really important distinction for me. And as I was saying earlier, it's not a distinction that's made in conventional medicine because across the board, a hypothyroid state, meaning the TSH is greater than a 4.5, they are given something called levothyroxine. Or Synthroid, that's the non-generic name of it. And levothyroxine is T4. It's thyroid hormone T4. Okay, and most of the time, I see patients don't respond that great to this drug. And there's a couple different reasons for this, which I will go into, and I often go into with patients who maybe they come in to see me and they have been diagnosed with hypothyroid years ago, and they've been on Synthroid or levothyroxine for 15, 20 years, but they still have thyroid symptoms.
Right. And as a matter of fact, those drugs have actually destroyed their thyroid by the time they come in, you know, being on it for so long, so they can no longer function properly.
And, you know, they said they started it, maybe they felt a little better, but really they felt like the symptoms still were there. Well, let's think about why.
Okay.
So levothyroxine is T4. T4 is the most abundant thyroid hormone. We have 80% of it, but it's not very active. It doesn't actually go to your cells and do what the thyroid is supposed to do at the level of the cells, because who does that?
Right.
T3.
T3.
Right? So we have to rely then on the patient taking this medication and rely on this T4, the synthetic T4 that they're taking that contains gluten, by the way, which is a whole nother issue. But taking this synthetic T4, levothyroxine, they have to then rely on their own body to convert it into T3, which is the actual bioavailable active form of thyroid. It doesn't work well.
Exactly. It's not going to happen.
It doesn't.
Right.
So, you know, I have this conversation with my patients, and generally, in terms of just talking about thyroid hormone itself, I am a fan of using a bioidentical form of thyroid if we're going to use hormone that has 80% T4 and 20% T3.
Just like the way the body's intended to.
Just like the way our own system makes it. And I find that people on that blend of bioidentical thyroid hormone replacement will do beautifully.
Great.
So that is talking just about sort of the hormonal piece of the puzzle. Now there's a lot of other things that I always want to look at. I want to look at, you know, why is the thyroid hypothyroid in the first place? What's the underlying cause? Is it an autoimmune cause? And if so, why did the autoimmune issue develop? For Hashimoto's, the two most common causes are gluten intolerance long-term, which has then created autoantibodies, or heavy metal issues in the system. Mercury, lead, formaldehyde, perchlorates, insecticides, all of those things we actually know, they're researched, they're documented, they impact the thyroid gland itself. So I am always going to be an investigator, and I'm going to try to understand these underlying causes, and then we will treat accordingly. In addition, we will make sure that their diet is correct. If they're doing a lot of goitrogenic foods, which are foods that can suppress thyroid function, we want to look at that. So soy is goitrogenic, peanuts. Some of the brassica or cabbage family vegetables, if done raw in large amounts, can be goitrogenic. And I will look at that. I will look at their nutrient level. Are they getting adequate iodine? Are they getting enough selenium? B12 is also very important for the thyroid. Tyrosine, an amino acid that's a precursor to the thyroid. I'll look at their diet in depth. And then definitely consider, if it's an autoimmune condition, that there could be a gluten issue and there could be heavy metal issues. Second part is we have to consider what other endocrine systems might be involved here. If it's just an hypothyroid state, there's no autoimmune condition, I always want to then look at something called the adrenal glands.
Exactly.
Because the adrenal glands and the thyroid work hand in hand. And as the adrenal gland is going through stress or changes, that can cause the thyroid itself to lose function. And if all we do is look at the thyroid and overstimulate the thyroid, those people will actually not respond as well, because an underlying cause is the adrenal glands.
Well, I would like to kind of go back a little bit and maybe talk about, you know, where you may find the heavy metals. What sources are people getting these heavy metals from? Because I know there are so many people out there with these heavy metals, but when we speak about heavy metals, you know, the first thing they always say is, oh, I don't eat fish.